Good evening, everyone. Good morning, Dr. Khoury. We are happy to have all of you here to listen to the lecture by our distinguished speaker, Dr. Tony Khoury from the University of California, Irvine. As all of you know, Dr. Tony Khoury is a well-known landmark in the field of pediatric urology. He graduated from the University of Ain Shams. He did his residency in the University of Toronto in Canada and did his pediatric urology fellowship in the Hospital of Sick Kids in Toronto. He has been the chief of pediatric urology in the Hospital of Sick Kids for, I think, 13 years. Then he moved to the University of California in Irvine, where he became the chief of pediatric urology for almost 13 years now. Dr. Khoury has over 300 peer-reviewed publications and over 30 book chapters, and it's really an honor to have him with us today. I would like to ask all of you kindly to hold a minute's silence to tribute the memory of our beloved Professor Dr. Salim Khalil, who passed away 10 days ago. Thank you all. Now, Dr. Khoury, now we have the lead. We are all eager to listen to your lecture. And please, everyone, I'd like to ask you to mute your phones and switch off your cameras so that we have a stable connection. Thank you.
Okay, hello everybody. It's a great honor to be speaking to my colleagues from Egypt. Next time, hopefully we can do this in person rather than virtually, but hey, it's better than none. Thank you, Ahmed, for asking me to speak about posterior urethral valves. And between our experience in Toronto and our experience here in Orange County, we have been analyzing our data on posterior urethral valves to understand how to best manage these children and give them the best long-term life. The one philosophy that I will hope I can impart on you is that if these children are managed well, yes, we all agree that 50% of them will end up in renal failure, but if they're managed well, instead of having the renal failure develop around age 6 or 7 and end up on dialysis and on the transplant list as very young children, we may be able to delay this to their late teens or early adulthood, where the results of transplantation are much, much better, and they've had their growth without immunosuppression, and their bones have developed nicely with normal native renal function. So having said that, what I thought I would like to do is address this from infancy through childhood through adolescence. And before I start, I want to remind us all that posterior urethral valves is not a binary problem. It's not a black and white problem. It's not whether you have valves or not. It's what part of the spectrum, and Hardy Hendren is the one that really taught us this, what part of the spectrum are you really on when we say somebody has posterior urethral valves? Because if you have posterior urethral valves and that's the impact on your bladder, and you've got minimal dilatation of the urethra and a little tiny valve leaflet here, this child will do really, really well, as opposed to this baby that has his bladder neck and posterior urethra are bigger than his bladder, which is really smaller than his ureters. So the spectrum is clear, and what part of that spectrum or continuum do you fall on, does your child fall on, determines the long-term outcome of as far as renal function, growth, and every other aspect that we'll talk about. So we'll start with the prenatal diagnosis of valves and see if intervention in the prenatal period really helps or not. Prenatal hydronephrosis is detected in approximately 1% of fetuses on prenatal ultrasound. And if you look at what diagnoses are noted, 50% of those are hydronephrosis, whether it's unilateral or bilateral urethral pelvic junction obstruction. 10% are duplication anomalies, 25% are reflux, and about 10% is valves. So it's 0.1% of all the children that are diagnosed prenatally with hydronephrosis. Lower urinary tract obstruction really is the most significant uropathy perinatally. The mortality rate ranges from 24 to 54%, mostly because of termination before, at least in the Western world, termination. And in places like France, for example, they can terminate up to 30 or 32 weeks in the pregnancy. In North America, terminations cannot happen after the 20th week. So when babies with severe posterior urethral valves are diagnosed around the 17th, 18th weeks of the pregnancy, many of these babies are terminated. Others are stillborn or experience intrauterine death. We're all familiar with the prenatal ultrasound finding of the keyhole appearance, the bladder and the dilated posterior urethra, giving that classic ultrasound description. And this is a child that was stillborn, and you can see the big dilated bladder, obstructed bladder, dysplastic kidneys, and the massively dilated ureters. And back in the mid-90s, late 90s, at Sick Kids in Toronto, we had a series where we tried prenatal intervention, stenting these bladders and shunting them percutaneously. And there's one such baby here. If you look carefully, you'll find that his bladder looked quite nicely. The big question, though, about prenatal intervention is, when do you intervene? Because if you are going to start noting the oligohydramnios by the 22nd or 24 weeks of the pregnancy, the lung dysplasia has already happened. And in the modern series today, the cause of death in these children is not renal failure. We can replace renal failure with dialysis in infants. The cause of death in these babies is pulmonary insufficiency. By the time you see significant oligohydramnios at 30 weeks, there's if the oligohydramnios develops around 30 weeks, the lungs have already branched and they're fine. So it's the children with severe valves who, the oligohydramnios by the 22nd week are the ones who you can't save their lungs. So in reality, if the intervention is carried out after the 24th week, then the intervention is useless as far as saving the lungs, and probably useless as far as saving the kidneys. And in a paper that was published by Craig Peters and Jim Mendel back in the early 90s from Boston, they showed that in the sheep model, because it was a controlled obstruction and they relieved the obstruction at the right time, they were able to prevent pulmonary hypoplasia from happening. However, in our clinical series from Toronto, for example, we noted that if you relieve the obstruction and your evaluation is based on, if I relieve the obstruction, do I improve fetal survival, do I improve pulmonary function, renal function, and bladder function? The answer is probably no. And let me show you some data to look at that. And why don't we make a difference? It's because the lung changes, the branching of the bronchioles and the pulmonary hypoplasia has happened well before the onset of or the detection of oligohydramnios. And the renal dysplasia has also happened earlier, and then the oligohydramnios sets in. So we've lost the kidneys, we've lost the lungs before we even intervene. And when do we intervene? If you ask yourselves, when do we really intervene? Well, you keep repeating the ultrasounds and watching and repeating the ultrasound. And by the time we intervene, on average, it's been past 30 weeks in the pregnancy. Back in the 90s, when ultrasound was not as advanced, we were concerned about intervening for the wrong diagnosis. Today's ultrasound is a lot more accurate. Maternal morbidity from the intervention, chorioamnitis, injury to abdominal content, intestinal herniation from the puncture site, from the defect in the abdominal wall, inducing preterm labor, and fetal death were all factors that make people a bit timid about intervening prenatally. So who are the candidates for intervention? If you have evidence of bladder outlet obstruction with a normal karyotype, no other major cardiac or brain anomalies, and there's no point intervening in a baby that has anencephaly or a single ventricle, because there's too many hits against that baby. A singleton pregnancy, documented oligohydramnios that was seen early enough and detected early enough, and the kidneys are still, the parenchyma still appears healthy, not cystic, and the urine indices are favorable, and we're all familiar with this. A sodium that's less than 100, a chloride that's less than 110, and an osmolality that's less than 210. And to remember those numbers, remember that the sodium and the chloride add up to the osmolality. And that's the typical vesicoamniotic shunting procedure. You have to do this under anesthesia so that the baby's not moving. You have to basically paralyze the baby so that you can go through the mother's abdominal wall, uterus, baby's abdominal wall, bladder. And that's why sometimes those shunts don't end up in the bladder, because they slip out or they go into the abdomen. But if you're successful, this is one of our success stories. This baby was born with a reasonable bladder, and at 3 years of age, he has a smooth-walled bladder, and all he had was resection of the valves, and he has no reflux and had normal kidneys. But here's another example of a baby that had multiple shunting procedures, because babies move in utero, and if you look here carefully, there are 3 shunts in the abdomen. One was in the chest, one was sitting right next to the spleen, one was sitting in the bladder, and 2 were floating in the amniotic fluid because they had fallen out, and one was in the baby's hand when he was born. So the baby reaches down and grabs those shunts and pulls them out. And so this baby had had 6 shunting procedures over the last 10 weeks of the pregnancy. But he did very well. Let's look at the results, and that was published in the Journal of Urology back, and this looked at a series that was a 10-year series from 89 to 98. This was from our high-risk multidisciplinary clinic. 6,000 pregnancies were evaluated, almost 90 children with valves, 12 were deemed suitable for prenatal shunting. The parents refused fetal intervention in 3, and 2 were terminated, and 1 was stillborn, and the other 9 underwent vesicoamniotic shunting. Of those, 1 was terminated, 2 were stillborn, and 6 were alive at birth and available for evaluation. So from 89 patients that were thought to be with posterior urethral valves, 6 had shunting and were alive at birth from the 12 that were shunted. So 50% mortality perinatally or prenatally. And then let's look at those 6 that were born after the shunting. 4 had a diagnosis of posterior urethral valves. Patient 1 had a kidney transplant, is doing well. Patient 2 had a kidney transplant, died from complications and sepsis post-transplant. Number 3 had a bladder augment and is doing well. Number 4 had a bladder augment and a kidney transplant. So, and he's doing well. 1 patient had urethral atresia, and his bladder ruptured during the shunting procedure. He created an internal vesicostomy for himself, and with that, he did very well. And the last patient was a prune belly variant with urethral atresia, and he underwent a bladder augment and did well. So 1 mortality, 5 alive. Of the 5 that are alive, 3 were transplanted and 3 were augmented. So you look at those numbers and you tell me, did we do well from a renal standpoint when we have 50% transplant rate? No. Did we do well from a bladder standpoint when we have 50% bladder augment rate, not as well. So the bottom line in my mind is, if you're going to shunt a patient, you really have to be very clever in detecting the patient very, very early, around the 19th, 18th, 19th week of the pregnancy, and shunt around the 20 or 22nd week of the pregnancy. And so in those cases, you know, how aggressive you're going to be with the shunting is really determines the success rate of the shunting program. And don't forget also that shunting, when you put a shunt in, you defunctionalize the bladder, and when you defunctionalize the bladder, it's not cycling, and therefore bladder growth, as you saw, the majority of our patients ended up with a bladder augmentation. So bladder growth is suspect in those patients. After birth, our job is to decompress the bladder with a 5 French feeding tube right away. In Egypt, most patients are circumcised, and I would encourage early circumcision in those because it does reduce the need for the number of children that develop urinary tract infections if they're circumcised or if their foreskin is retractable. They're all put on prophylactic antibiotics, and their acid-base fluid and electrolyte imbalances are corrected. Once the baby has been stable for 4 or 5 days, and we watch what's happening to the creatinine. As we all know, the serum creatinine initially is mother's creatinine, which is 1 in our numbers here, or 100 in the international numbers. And our expectation is that this is going to drop 10% per day, so that by day 5, it's about 50% down. And if that happens, then I simply resect the valves and watch the children. Other options in early management is resection and immediate reconstruction as far as their reflux and their reimplanting their ureters, versus delayed reconstruction, versus an early vesicostomy if you don't have the equipment to resect the valves. You're in a remote area and there's no equipment to resect the valves, although there's always the option of putting a catheter in and sending them to a center that has the equipment. A high diversion, and that used to be something that was popular 30 years ago, and I think less and less people are doing that, and I'll spend a couple of minutes on that later. The role of prophylactic antibiotics, anticholinergics, and alpha blockers early on, and there was an excellent paper from Mansoura, from Ahmed and Ashraf, talking about the value of anticholinergics in a randomized fashion. And then the value of overnight catheter drainage, and I'll talk about the rationale for that later. So let's explore some of these options. My favorite piece of equipment for resecting or incising valves is the Wolf Urethral. And I use a cold knife, it's a sickle blade, and I use that, and I'm successful in greater than 90% of the patients at birth. It allows the bladders to cycle, and I do that regardless of everything else that's present, whether they have reflux or not. This is the short movie of the resection, and this is one of my fellows resecting the valve. And the reason I'm showing that is to demonstrate to you how simple and easy it is to incise the valves with the cold knife. The bladder neck in these children is usually elevated, and as we come back from the bladder neck, we'll see the variomontanum, and then the valve leaflets snap shut right away as we enter the membranous urethra. And the procedure with and this is live, and this is not an edited video, and you can see you'll see how simple the procedure is. The sickle blade, you have to introduce it into the bladder, and then as you approach the valve leaflet, the cutting blade is at the 5 and 7 o'clock position. Some people prefer to incise at the 12 o'clock. That's also fine. All you need to do is watch that the tip of the blade does not scrape the mucosa of the floor of the urethra here. Keep it above the floor and just engage the leaflet. You'll see the tip of the blade here, and with one quick slice, that side is done. Okay? You might want to clean up a tiny bit. He left a tiny little leaflet there, but that side is done. and you do the same thing. I do 5 and 7 o'clock usually. It literally takes 3 minutes to resect the valve and leave a catheter in for 48 hours, and then try and see how well the child urinates after that. So again, engage the leaflet, keep the tip off the mucosa. If you do it this way, you can see there's no bleeding, and there's the risk for stricture formation. Sorry, why is that playing again? How do I, there we go. The risk of bleeding is negligible. You don't need to use cautery. But the key thing, when we started using this cold knife resectoscope back in 1995, so that's what, 25 years ago now, we have not seen a single urethral stricture related to posterior urethral valves. The incidence of strictures in the past used to be 15% when people were using cautery or the Bugby or all sorts of other devices. In 25 years, I have not seen a single urethral stricture after resecting valves. And here's a child that you can see has got severe posterior urethral valves, massive bilateral grade 5 reflux with bladder diverticuli on both sides. And you would think this, I mean, this is a case that 25, 30 years ago, I would have done a vesicostomy for. This is a case from 2008, and I'll show you some follow-up on this child. I only resected his valve. That's all I did. I resected the valve leaflet here, and I watched him over the years, and you can see his bladder grew and improved. His reflux is still there, but it's much, much better. This child did very well over the years. His creatinine is normal. He has not had a single infection except once when I repeated his VCOG to see how his reflux is when he was 7 years old. I repeated his VCOG, and he had an infection after that VCOG. Prior to that, he had 0 infections and no issues whatsoever. His kidneys were growing, and he was emptying his bladder very well. So this is clearly an option in at least 90% of the patients. Now, what's the prognosis for children born with severe valves like that? Some people have tried to look at single factors that determine the outcome, whether you do a vesicostomy or not, whether you do a pilostomy, whether you resect the valves, their grade of reflux, how thick the bladder is. They've looked at a multitude of factors. In reality, this is a multifactorial problem, and you cannot evaluate or predict the outcome based on a single factor. And so let's look at some of the factors that are involved. In the prenatal period, how significant was the oligohydramnios? Did the child have progressive bilateral hydronephrosis? Was there cystic dysplasia in the kidneys? Were the fetal urine parameters off? And based on this, you can say, if there was no oligohydramnios, hydronephrosis was stable, the kidney parenchyma looked good, you're in the good prognosis side. Otherwise, the more these parameters are off, the more you are on the poor prognosis side. If you were born with pulmonary hyperplasia and had renal failure at birth and you couldn't bring the nadir creatinine down below 2, then you're in trouble. If you had multiple episodes of sepsis, like many of the children in the Middle East who are not diagnosed immediately and they present with dribbling a year or so out and have had multiple episodes of pyelonephritis and sepsis, these children don't do well. If your nadir creatinine, by that I mean the lowest creatinine you were able to bring down, is below 0.6 or 60 in your units, you do well. If it's over 2, that's not so good. You need to work very hard on those children. And sometimes nephrology will give up on a child whose creatinine is born at 2. And we've had a recent example of that. And I've taken this child back and done a high diversion for him. And his creatinine has moved all the way down to 0.4. And at birth, we had the family meeting with the parents. This child is now 14 months old. His creatinine was 2.2 and wouldn't budge with a catheter in. And I told the family, we'll do a high diversion and we'll see what happens. And his creatinine nephrology said, you're giving them false hope and you're operating on that child for nothing. But his hydro was not getting better. And so I felt that there's issues with his urine transport through the ureter. So I said, let me give it a try. And the family agreed. His creatinine now at 14 months is 0.4. So a much, much different prognosis than if we had left him with a creatinine at 2 at birth and carried that through age 14 months. He would be in renal failure by the time he's 4 or 5 years old. If you stabilize the GFR below 40, that's not very good. If you get it above 60, you're in much better shape. If your kidneys have cystic changes bilaterally, if the ureters are massively dilated and are not draining, you need to do something better for that child. So there are 7 reasons why these children go into renal failure, the causes of their renal damage. If they're born with dysplasia, if their hydronephrosis is not improving despite your drainage procedures and you do nothing about it, if they have if they have reflux nephropathy, massive reflux and reflux nephropathy, if they have recurrent pyelonephritis, if they end up with the hyperfiltration glomerulosclerosis situation, if their renal circulation is low, and if they develop hypertension. These are all mechanisms that set children up for renal failure. Now, if we are to understand the pathophysiology of valves, it's important that we understand this coming segment here, because that determines how best to manage these children. Because there are 10 problems that cascade, and depending on the severity and how reversible they are, they determine the outcome as far as renal function, as far as growth, and they determine your decisions as far as management. So we're starting with a little valve leaflet at the outlet, just a flimsy little valve leaflet that causes voiding inefficiency during in utero, with significant detrusor storage problems. It affects capacity, compliance, and contractility, resulting in high pressure in the bladder and destruction of the urethrovesical junctions with reflux. The dilatation of the ureter results in inefficient peristalsis, because we all know for peristalsis to happen, the ureter opens up, receives the bolus of urine, coapts and isolates that drop, and then milks it down. If I have a very dilated ureter, there's no way for me to be able to effectively create peristalsis. And as a result, the more the ureter dilates, the less the peristalsis is efficient and effective. And if I don't peristalse, then there's no pumping effect to deliver urine from the kidney down to the bladder. Gravity helps if the child is standing, but if the child is lying down, the only pumping effect is the filtration of the GFR that pushes 1 drop of urine forward. As the pressure rises, it just keeps pushing based on pressure gradient, which causes more dilatation. So the real pump in that system is the heart, which is causing the GFR, the glomerular filtration. Now, I'll ask you a question. Think about this. As in the embryology of the kidney, we all know that the urethral bud goes up from the bladder, branches in the tissue that's going to be the renal blastema, and that branching is what induces kidney formation. What's the most terminal branch of the ureter in the kidney? We know the pelvis, and then major calyces, minor calyces. Think about that for a second as I progress here. As a result of all of the above, we end up with renal damage from that urethral obstruction, that as it promotes infection, and the infection is one of the important factors in renal damage. And because of the obstruction, we are increasing the degree of dilatation. And the more the ureter is dilated, the more, and the answer to my question is, the collecting duct dilates, because that's the terminal branch of the ureter, the collecting duct in the nephron. And when the collecting duct dilates, we all know that the collecting duct is where concentration of urine happens. So when the collecting duct dilates, the aquaporins and the ADH can't do its job, and we end up with more dilute urine and more polyuria. And that drives a very vicious cycle, because the polyuria results in more dilatation, and more dilatation causes more polyuria. And that's a cycle that we need to break. And that's where that overnight catheter that we'll talk about becomes very, very useful. As a result of the renal damage in the prenatal period, we see this as oligohydramnios and pulmonary dysplasia. And then after birth, we see these children developing growth problems, anemia, osteodystrophy. And that's that cascade that we're talking about. Now, reflux, as I showed you in the VCOG of the child that just underwent the resection, is present in 50% of patients with valves. It's secondary reflux. So beware of correcting reflux in these children. Doing a correction of reflux in these children is fraught with danger, because it's a secondary problem. And if you don't correct the high pressures in the bladder, that secondary problem is going to persist. And we've inherited so many patients that were referred to us after the child has had multiple reimplants for a valve in a valve bladder, and the reimplants obviously have failed. They've developed obstruction, which compounded their problems, or they had persistent reflux in worse grades, and they've had more infections and more trouble. If you correct the outlet obstruction and you correct the high pressures in the bladder with oxybutynin or with whatever means you wish to correct it, a third of the reflux will resolve, a third will remain stable, and a third will require surgical correction, but much later and in a very careful way. This is another example of a child who in 2008 was born with a posterior urethral valves, bilateral grade 5 reflux. Right kidney was hit worse. You can see the ultrasound on the right kidney. The renal scan demonstrated 25% function here, 75% function on the left side. And he only underwent a valve resection, and I watched him like a hawk. And again, you can see his hydronephrosis is reasonable, improved. The right kidney is still echogenic, but the left kidney has good corticomedullary differentiation. And there's his bladder now. This is in 2019, so this is, he's 11 years old. There's his bladder, nice and smooth walled, normal urethra, no strictures, persistent reflux on both sides, no infections, normal creatinine at age 11 of 0.6. So it's very reasonable if you have families that are compliant, will come back to see you, will bring the child, they have access to care, will bring the child when the child is ill or sick, and will come for their yearly ultrasounds, their yearly flow rates, because that's all I follow. I don't repeat VCOGs on these children. As long as they have stable renal function on their blood work, their ultrasounds show stable or improving hydrourethral nephrosis, they remain infection-free, and their flow rates, they empty their bladders well. If they fulfill these 4 criteria for me, I'm hands-offish. I don't do surgery for their reflux, and I don't touch their bladders. Now, if they're incontinent, if they're having issues with bladder emptying, if they're coming with recurrent infection, that's a different story. They need attention. When do I do a vesicostomy at birth? I actually now don't do a vesicostomy anymore. I'll show you what I do. But who do I divert at birth? Primary, only 5% of my patients. The ones that have massive reflux, who with a catheter I can't get their hydronephrosis improving, or even if I resect them and their bladders are so small that they're storing in their ureters, they're having recurrent infections, their renal function is not improving, or they're tiny and I can't get a scope in them. Secondary, if I've resected their valves and they still have progressive, like the baby I talked about, deterioration in their renal function, They have progressive hydronephrosis, their reflux is getting worse, the urethral diameters is getting worse, they have recurrent infections, and again, if they have inadequate bladder storage or emptying. What's the outcome of vesicostomy? People are worried that if you divert by a vesicostomy, these children don't do well and they end up with shriveled up bladders and they all need an augment. That is not true, and we've shown that back when I was a fellow in the late 80s, early 90s. We wrote this paper up. Diversion has no impact on renal dysfunction due to dysplasia and scarring. That's a given. You are not, if you have dysplasia, no matter where you divert, you're not changing that. But it does reverse the bladder hypertrophy, and it does reverse the urethral dilatation and the inadequate transport and peristaltic activity. It does not immediately change the bladder matrix. The collagen that's formed, the stiff collagen that's formed that's protective against rupture, persists for a while, but eventually that remodels in the first couple of years of life. If you divert a child in a non-infected bladder, you do a vesicostomy, those bladders recover usually. If you do a vesicostomy when the child has pus in the bladder and the child is really septic, those bladders scar down and shrivel up, and they eventually would need a bladder augment. What I do now, if I need to divert someone, is I do a loop cutaneous ureterostomy on one side. And what I do is I take one ureter, bring it out for both limbs. And what that does something very good for me, because it allows that bladder to continue to cycle. So the urine draining from this kidney comes straight out through the upper limb of that loop ureterostomy. And the urine coming down from this side will reflux up that ureter and drain also through the loop. So this way, the one kidney is continuously cycling the bladder, and I've drained both kidneys and popped off the pressure so that there's no pressure in the bladder, and that bladder gets better really quickly. I try that first before a vesicostomy so that I don't have a dry bladder. Vesicostomies in valve children who have a tiny, small, stiff, thick-walled bladder is not an easy operation. It doesn't come out to the skin as easy as a reflux bladder does. But a big, massively dilated tortuous ureter, like the examples I showed you on the VCUG, will come out to the skin without difficulty at all. The advantage of this loop is it also allows two things. If the bladder is not, if I wanted to leave an indwelling overnight catheter in this child, I can catheterize it through this limb very easily. And if this ureter is tortuous or there's a secondary uretropelvic junction obstruction here, I can pass a catheter in that kidney intermittently and drain that kidney too. So this is, in my hands, has been very, very useful. I've been using that for the past maybe 10, 12 years. And I do very, very few vesicostomies because of that procedure. When do you do a pilostomy? Rarely, extremely rarely. It has a very limited role. If there's fungus balls in the renal pelvis, that's a good idea. If your child has recurrent pyelonephritis, secondary UPJ, the ureter is massively dilated, you can't get that ureter to drain at all, there's multiple tortuous folds in it. It also allows you to do a biopsy of the kidney at the time if you wanted to prognosticate. If you do it bilaterally, it may have a negative impact on bladder function. It does not change renal function if there's dysplasia. If you're going to consider a pilostomy, instead of just bringing the pelvis to the outside like that, consider doing a sober pilostomy, in which what you do is you anastomose the ureter to the pelvis in an end-to-side fashion here, so that when time comes to reverse the pilostomy, all you need to do is close this. Because reversing this guy can be difficult. There's a lot of scarring here, and it becomes difficult to do the pyeloplasty to re-anastomose the ureter to the pelvis here. Do it this way. You've done this in the absence of any scarring, and you've got a wide open anastomosis. It also allows some urine to preferentially go down into the bladder and maybe cycle it a bit. But closing this sober pilostomy is very, very simple, and is all you need to do is close the skin stoma. Now, a child comes to your clinic to evaluate for follow-up. I teach my fellows to do a 10-point evaluation, and most of the fellows that have trained with me can recite this slide verbatim. No child should come into your clinic that has not had a weight and height if they have valves. Their blood pressure should be checked every single time. Their nutrition should be evaluated. You need to evaluate their glomerular and tubular function. We talked about the lack of concentrating ability. So their GFR needs to be checked blood work-wise, their eGFR, and their ability to concentrate and their overnight urine output. They need their ultrasound. On ultrasound, we need to evaluate the degree of hydrourethral nephrosis and consider if they're developing a secondary urethropelvic junction obstruction. The urine transport through the ureter, is peristalsis effective? Is the ureter dilating more and more, or is the ureter coming down nicely and draining into the bladder? We want to make sure that there's early on the hypertrophy of the bladder is not causing impingement at the uretrovesical junction and causing obstruction to drainage. Also want to know that what is happening with their reflux. What's happening with their bladder storage, the 3 C's of storage: capacity, compliance, and contractility. What's happening with their ability to empty on their flow rate, or if they're not toilet trained, they're post-void residual, they put a dry diaper on, keep checking it, and as soon as they empty, a quick ultrasound of their bladder. What's happening with, their infections? Are they needing prophylactic antibiotics? Are they getting recurrent infections or not? Are they continent or not? And what's happening with their urethral conduit? Because remember, if they've had their valves resected using energy, using electrocautery, there's a 15% chance that they will develop a stricture in the urethra. So these are all issues that need to be evaluated and assessed as we move along. On every clinic visit, that has to be documented. We talked about 50% of these patients developing renal failure, and that happens at a very time in their life. We talked about all the factors that promote that. The one you and I cannot change is renal dysplasia, but everything else, from the renal pelvis down, you can impact on if you have a family that works with you. So your job is to shift the time of renal failure all the way to the right. We don't want renal failure in the first 4 or 5 years of life. We want if we're going to have renal failure, let's have it when they're 20 years old and they're fully grown. How about the adolescent population? The adolescent population, we studied our long-term valve patients when I was in Toronto, and we looked at the initial management, whether they were diverted by vesicostomy or pylostomy or whatever, versus primary valve ablation. There were 53% of the diverted patients, 19 out of 36, developed renal failure versus 34% of the patients that had primary valve ablation. Now, you could argue that the patients who were diverted were the ones that had on the more severe side of the spectrum. And that is true, because their mean creatinine before their diversion was 200. They were in renal failure. That's why they were diverted. The children that did well with catheter drainage are the ones that had valve ablation. And so, to say if you get a diversion, you end up in renal failure, no, that's wrong, because Philadelphia was pushing that. That is wrong. You get a diversion because you were really sick and needed a diversion. And the argument to that is, if I hadn't diverted you, you might have had renal failure in 75 or 80% of these patients, not 53. What happens to bladder capacity over time? And I'm putting that up because I discourage most of my fellows from considering bladder augmentation early in these patients. I'll show you example after example of bladders that looked horrible at birth, and eventually they evolve and they become normal bladders. Because biology is amazing, growth is amazing. If you give that child the right circumstance and the right conditions for growth and developmental biology, that bladder will recover and will grow, okay? So we looked at the evolution of bladder capacity over time. We looked at the impact of ablation versus diversion. We looked at voiding efficiency over time, the number of children that ended up with bladder augments, and the relationship of end-stage renal failure in relation to initial management and nadir creatinine. And let's look at some of that. The adolescent valve bladder results from poor sensation. As we all know, many of these children are comfortable with very large bladder capacities as they go through adolescence, late childhood and adolescence. They have sensory issues. The bladder distends and they don't feel it because of the high-grade reflux that they had. They don't develop that proprioception that triggers them to go urinate. And they frequently have overflow incontinence and void very infrequently and incompletely. And that's why it's so important that on every one of your follow-ups, you get a flow rate and post-void residual on these children, and you teach them to double void and triple void until they can get their capacity down. And why is that important? Because if I have a 400 cc bladder and I'm emptying only 200 cc's, I'm always storing in that high pressure zone. If I empty down to 0 and I empty every 200 cc's, then I am emptying in or storing in the low pressure zone continuously. So if I get these children to void every 2 hours and double void, they're storing here. Their urethral dilation will improve. Their hydronephrosis will improve. If I let them overflow and just empty back to 200 and constantly here, their hydro will get worse with time. So my message to you is improving their emptying by double voiding, triple voiding, frequent voiding, or intermittent catheterization if needed, improves their storage. I'll repeat that because it's important. You improve a child's emptying, you improve their storage. In our series, 15% of our children end up on either CIC or overnight catheters. These are the ones that have persistent urodynamic changes, whether it's detrusor overactivity, poor compliance, poor capacity, or post-vesicostomy closure. In those children, 30% of the vesicostomy patients had inadequate compliance, 20% was borderline, but 50% had normal compliance. The voiding inefficiency is caused by multiple factors also. They can have a decompensated bladder, myogenic failure of the bladder. The bladder is mostly connective tissue and very poor detrusor fibers. They can have abnormal outlet, either stricture or dyssynergia. They can have high-grade reflux that dissipates the energy of their detrusor contraction. So it's like squeezing a toothpaste tube from the middle. Half the urine goes up and half the urine goes out. So when you look at a child that's not emptying, don't just think of their urethra as the problem. Could be a combination of bad urethra, bad bladder, and high-grade reflux, and all these have to be taken into consideration. When we look at the patient population that was born between 85 and 95, in whom we had at least 10 years of follow-up, so that we can follow them for 10 years, and that went through adolescence, there were 78 patients. 12 had undergone bladder augmentation, so they were excluded, and 66 had their native bladders, and their bladder capacity was evaluated. This is what happens to them. These are the same group of patients over time as they come with their bladder diaries and their flow rates and post-void residuals over time. You can see that in the first 10 years of life, this is their expected capacity here, 100% of expected capacity. You can see that in the first 10 years of life, the majority cluster below their expected capacity, anywhere from 20% of their expected capacity to 100% of expected capacity. However, as they get older, the majority of them have bladders that are larger than expected capacity. Very striking. So the message here is, don't jump in and augment these kids, because the majority of them post-puberty will develop large capacity bladders that will be larger than their peers. Does it matter whether their initial management was diversion, vesicostomy versus valve ablation? Not really. There's not much of a statistically significant difference between those two groups as far as bladder capacity. How about their post-void residual? In the younger age groups, this is the proportion of children without post-void residual, and this is the proportion of children with greater than 10% post-void residual. You can see that as the child goes through childhood, that increases. As they learn more, as they're older and they learn more and they become more responsible, double voiding and triple voiding, their post-void residual starts to decrease. As they go through adolescence, depending on how compliant they are, you can manage them really, really well. The majority of them do well without catheterization and without, simply with frequent voiding every 2 to 3 hours and double voiding, i.e. they go back 10 minutes after they've urinated and pee again to drain whatever was in their ureter and whatever was left behind. When do I do urodynamics on these children? Rarely, very rarely. These are sensate boys and it's difficult to catheterize them and they don't like being catheterized. So if the child is stable, their ultrasounds are stable, all the points of evaluation that we looked at were stable, I don't do. I get most of my information from their history and physical, from their bladder diaries, from their uroflow and post-void residual. It's all I need and I can tell you exactly what the urodynamics is going to show. If they have a normal ultrasound, they're emptying their bladder completely, their storage is going to be fine. Thank you. You don't need to document that with a urodynamics. On the other hand, if they're progressively becoming hydronephrotic, if their bladder is more trabecular, if there's changes there, I'll do a video urodynamic to try and understand what's going on. If I'm contemplating an intervention, I'll do video urodynamics on them to try and see what's going on. But remember, if they're deteriorating, check first that they're emptying well, because if they're not emptying and if they're holding high residuals, their storage is going to be impacted like we talked. What's the valve bladder? The valve bladder, the definition of it is a combination of bad compliance with bad incomplete emptying, and because of the lower concentrating ability from the dilated ureters, you end up with polyuria, and that promotes the high pressure storage, the further dilatation, and the incomplete emptying. So it's a cascade of events that need to be broken. And the best way to break that is with the overnight catheter. Put a catheter in, let it drain all night long, give the bladder and the kidneys a 12-hour break. So as I wrap up, I'm running 5 minutes late, sorry, Ahmed. In summary, prenatally, we talked about the role and value of prenatal intervention, and I outlined to you that if you're going to intervene, you need to identify the patient that is the good candidate for intervention and intervene around the 22nd week. Waiting longer has no value, and if you intervene and you drain that bladder, remember you're not cycling that bladder, and so that bladder will be a small bladder, and many of these children will require augmentation. If the child already has oligohydramnios, then the lung and kidney branching has already happened, and the ability of prenatal intervention to reverse these changes is very, very limited or zero. So if you're going to do that, you need to make the diagnosis early and intervene very early. In infancy, we talked about management at birth and the importance of preventing infections. And we talked about primary resection as the modern way of doing this, and not jumping into diversions unless you can't or you don't have the equipment to resect safely. We talked about the factors that predict the outcome, and we reinforced the importance that we think of this as a multifactorial problem rather than if I resect or if I divert or if whatever. We also talked about the decreasing role of diversion. We said 90% of the patients do well with primary resection, and that aggressive management can delay the onset of end-stage renal failure. If your child is not doing well, if there's progressive hydro, jump in with more aggressive intervention, whether it be higher diversion or more intermittent catheterization or whatever surgery is required. Be careful with reimplantation in the valve bladder. It's not for the faint of heart. It's a difficult operation and the results are not the best. So with careful management, the majority of valve children have excellent bladder storage over time. Most are able to empty to completion. 15% will need clean intermittent catheterization. The poor concentrating ability and the nocturnal polyuria benefits from overnight catheter. If you do a short period of temporary diversion, 3 to 6 months with a vesicostomy, it does not negatively impact eventual bladder capacity as long as you've treated the infection before you do that. And if you divert the child, you may delay, but you don't prevent the eventual renal failure. Finally, if you are looking after a child with posterior urethral valves, you are committed to lifelong care for this child. It's not a matter of resecting the valve and sending the patient to the nephrologist or their pediatrician. You need to follow this patient for life. And these children need special care, especially around puberty and adolescence, because they grow fast, their muscle mass puts more demand on their kidney, their creatinine will rise faster, and they neglect all the instructions you gave them about drinking water and about voiding frequently and double and triple voiding. Thank you very much for your attention, and thank you again for the kind invitation. If we have a few minutes, we can answer a couple of questions.
Thank you so much, Dr. Khoury, for this very informative lecture. It actually provoked a lot of questions as usual. So I will try to wrap those questions and summarize so that we can answer most of them. So you mentioned that you rarely do urodynamics for patients with valve. For those who improve, you don't need to do urodynamics, and you just observe based on the clinical progression, improvement of hydronephrosis, and so on. A lot of studies or papers now are putting urodynamics as an essential part of evaluation of patients with valve. And how do you use urodynamics, or what's the place of urodynamics when you treat your patients following valve or successful valve ablation? A lot of them persist with hydronephrosis, reflux, and so on. So it has a lot of limitations. The urethra is sensate. It's difficult to do. A lot of them have high-grade reflux. How do you utilize urodynamic information to judge your further clinical management, or when do you start with anticholinergic, alpha blocker? When do you divert your patients?
Right. So in my mind, if a child is doing well, on serial ultrasounds, their hydro is better. On their flow rates or their post-void residual, if they're in diapers, they're emptying their bladder completely. What is urodynamics? How is urodynamics going to help me? What change will I do based on urodynamics?
Yes, I agree for you, for those who are improving.
Exactly. So if the child is not doing well, that's a different story. Mm-hmm. Now you're talking a different scenario. If the child is not doing well, why is he not doing well? Does he have an issue with storage, or does he have an issue with emptying? Mm-hmm. If it's a storage issue, then urodynamics obviously will help, because I'll be able to determine what component of their storage is inefficient. And you hit on an important point, Ahmed, and that is that the child with poor storage who has high-grade reflux, their urodynamics may be falsely normal, because the ureter has more compliance and better compliance than the bladder. So you can fill the bladder, and if they have early reflux and a massively dilated ureter, your urodynamics is useless. So people have tried all sorts of things, putting balloon catheters in the ureters and doing urodynamics with that. But if the issue is, if you're seeing on the ultrasound that the ureters are dilating more every study, despite the child working hard on emptying, then what's the problem? The problem is in the capacity, compliance, and contractility of that bladder. If you start that child on anticholinergics and it impacts their emptying negatively, and they can't tolerate a catheter, then you need to do something better for them. Whether that be a Mitrofanov, or if the family is not going to do CIC, then, and it's a baby that's in diapers, do that loop cutaneous uretrostomy that we talked about. Because over time, given the right conditions, most of these bladders, if caught early, will improve. Now, I'm not talking about the child that is born in a small village somewhere that never shows up to you for 2-3 years and then shows up with a totally scarred, shriveled up bladder. I mean, that's a hopeless situation. I'm talking about the child that you've seen at birth, and you followed at birth, and there was good compliance with the family. So your evaluation depends on who it is, the patient. You can't make a blanket statement of doing urodynamics on every child with valves or not doing urodynamics on every child with valves. But if my patient is not doing well and I'm contemplating a change in management, yes, I need to gather all the information. And I scope those children, and I put their urodynamic catheters in the operating room, then take them to the urodynamic suite and do the urodynamics. and I do a video urodynamics, standard urodynamics without video, without fluoroscopy in these children is useless. You do need to see when the reflux happens and how much is refluxing into the upper tracts.
So it's easy, yes, I agree with you. It's easy to rule out obstruction by cystoscopy, but for those storage issues, how do you tailor your management, or in what way you start your treatment? Do you start with anticholinergics? Do you start with CIC or both, or do you sort out to diversion with a loop cutaneous uretrostomy?
Right. So it depends if the child is in diapers or not. If the child is young, year-old, 2-year-old, still in diapers, then a simple diversion without putting the family through catheterization usually helps a lot. And with that, I'll do the loop cutaneous uretrostomy. If the child is older, 4 or 5 years old, and their creatinine is rising, their hydro is getting worse, their urethral diameter is getting worse, then these are the children that I'll do an evaluation. I'll start with a simple bladder diary and flow rate and post-void residual. If they show me that they're not emptying and their bladders are, they're holding back 100 cc residual and their ureters remain dilated, then I need to do something about their emptying. If they're showing me that their bladder is all shriveled up, then I'll do anticholinergics, but be careful, because you know what happens with anticholinergics when you have pop-offs in the ureters, their emptying will be impacted. So in most of those times, you're going to need to do intermittent catheterization if the child has deteriorated on you. If they're not tolerating the intermittent catheterization, then these are the children that you need to consider doing a metrophenol for, so that the family can catheterize their metrophenol. If you have a family, what if you have a family that says, hell no, I'm not doing I'm not sticking a catheter in my child. And we've all seen these families that are just not going to. Their living conditions don't allow it, and they have no interest in catheterizing. They feel they're traumatizing their child. Then you have no option but to do a vesicostomy or a loop cutaneous uretrostomy.
Ahmed?
Yes, that's right.
Dr. Khoury, Haitham Badawi with you. Can I ask a question, Ahmed, please?
Yes, of course.
Dr. Khoury, for how long, first of all, what side you choose for doing the loop uretrostomy, the criteria for choosing the side, and for how long you leave this diversion, and what are the criteria for closing and timing for closing the loop uretrostomy if you do the diversion?
Right. Yeah, that's a very important question, Haitham. So my answer to you is it depends on what is the purpose of the loop. So if the purpose of the loop is better emptying of the bladder, or is it protection of the upper tract? If I'm concerned about if the child has the VERD situation, for example, where one kidney is not working at all and the other kidney is the better kidney, and I'm trying to protect the working kidney, then I'll do the loop on the side of a good kidney. And that's for 2 reasons. One is if the bladder is no good and I have a massively dilated ureter on the other side, I may want to use that ureter for bladder augmentation later on. So I leave that ureter intact without touching it, and my goal is to protect the good kidney, so I'm diverting it with the descending limb of that loop cutaneous uretrostomy. If on the other hand, I have a bladder that is marginal and I want to cycle the bladder more early on in infancy, then I might do the loop on the bad side and leave the good ureter intact if the high degree of reflux is not too bad on that side, so that ureter peristalsis is reasonable on the good side of the kidney. Then I let that peristalsis into the bladder, and if there's massive reflux on the other side, let it reflux out this way easily at low pressure. So you base it on what your goal is for that child.
Yeah, and for how long you leave it?
So if you're doing it again for, you're trying to improve the bladder, if it's all trabeculated and shriveled up and it will take a good 6 to 12 months. And there's no rush. If I'm doing it in early infancy, I'll say your child's in diapers anyway. Wait 2 years. Yeah. Wait 2.5 years until the child is exhibiting signs of ready to be potty trained, toilet trained. they're controlling their stool in a toilet, and they're wearing a diaper only for their urine, then yeah, push, go ahead and fix it then. But if it's a 4 or 5 year old that was trained before and now you're putting a diaper back on, and by the way, they don't have to be in full diapers. You can just take a diaper, fold it backwards, and stick it on the loop, on the stoma, and hold it there with the underwear. And that usually keeps them reasonably dry. So, you know, it depends on the age. So in that situation, the family usually pushes, let's be done. So you stabilize them, you see what's happened to their creatinine, because you've done it for a rising creatinine, obviously, and a progressive hydro. And that gives you time to talk to the family, to counsel them, to advise them. What do they want to do long-term? Do they want an augment? Do they want a Mitrophanov? Do they want a long-term diversion? What's their situation? You start working with them. Having the loop there gives you an opportunity to teach them to catheterize the descending limb of the loop and see how they're going to react to a Mitrophanov, or even to using that ureter as a Mitrophanov. How are they going to react to that? Are they going to be able to handle it? Or do I have to start thinking about other options for them?
How you pick your children who are in need of nocturnal drainage? And if you decide to do a nocturnal drainage, do you perform a Mitrophanov, appendicovesicostomy for that reason, or you use it per urethra?
Mostly per urethra. Mostly per urethra. It's hell to teach the families. I have one nurse that's very good at it. It takes her about 3 or 4 sessions. And I tell people, the families, that it's like when you first started to learn how to use contact lens. And many of us have used contact lens at some point in our lives. And the first week when you're putting contact lens in your eyes, it's miserable. Remember? Have you ever done contact lens, Haitham?
No.
Okay. Well, you tell someone, stick your finger in your eye. And, you know, for the first week, they start going like that and like this, and it takes them about an hour to stick the lens in. And after about a week, they just don't even think about it. You see women driving their cars and throwing contact lens in. And it takes like 30 seconds to do it. And the same thing happens with catheters, especially if the child is an infant.
And how you pick them up, those patients who are in need of nocturnal drainage, your indication?
Right. So if they are incontinent in the morning, right, you know that they're progressive. If their ureters are, remember what I said, if the ureter dilates, your collecting ducts are dilated, you're going to be polyuric. So if you do their bladder diaries and their first morning voids are massive, right? They're voiding massive amounts first thing in the morning. You know that your overnight volume should be less than 1/3 of your daytime volumes. And if it's 50-50 equal amounts or even more at night, you know you need to do something about it. And I give the families that fail miserably, I'll tell them, okay, what time does your child go to bed? 8. So make sure he urinates before he goes to bed. What time do you go to bed? Midnight. Wake him up and take him to the bathroom at midnight. What time do you wake up in the morning? So some families, the father or the mother wakes up at 5 to go to work. Make him urinate at 5. So then you don't go beyond 3, 4, 5 hours without urinating at night. So wake them up a couple of times in the middle of the night if overnight catheter is not an issue, is an issue for them.
Yeah, thank you. Thank you.
Do you have a place for bladder neck incision in your practice, Dr. Khoury, for those who still have some voiding problems after bladder ablation?
Never. You know, I usually don't answer questions with never, but never. Okay? Why would you take something that is not the cause of the problem and make it a problem in the future? If you reverse the bladder neck hypertrophy and you've incised it, then you've taken away, then you're more likely to make those kids dysenergic because they constantly have to contract their striated muscle sphincter. The bladder neck is not the problem here. The bladder neck is in response to the valve leaflet and is in response to the detrusor overactivity and and the contractility of that bladder. The bladder neck will improve over time. You look at the serial VCUGs on these children that you followed for time, that elevated bladder neck is gone after 2 or 3 years.
Fair point. I think Dr. Ahmed Hanno has a question. Dr. Hanno?
Yes.
You
Okay.
are
Can
very
you hear me?
Yes.
Okay. Tony, how are you? I'm Ahmed Anu from Alexandria. I hope you remember.
Yes, of course.
Thank you for your effort. My question is, what do you do to improve the results of ureteroneocystostomy if you are obliged to do it due to infecting reflux? I am asking because I have so many kids referred to me from surgeons who did primary ureteroneocystostomy, and they are all suffering miserably. My solution for it is augmentation plus a Mansoura-style subserous tunnel. But I think that this is too much. Do you have any tricks to improve on reimplantation? Particularly, usually it is a recurrent procedure.
So when we think of who is the patient that ends up with a reimplant, it's a child that has been having recurrent infections. And it's usually someone who has not had all the other 10 factors that we talked about addressed. The infections are secondary, and the pyelonephritis is secondary. The reflux in itself does not cause infections. It's the instrumentation that we do. It's the repeat VCUG. It's the inadequate voiding. It's the, so if we attend and look after all and prevent all the factors that cause infections, reflux will not be a problem in these children. And the most important thing is to ensure adequate emptying. Now, I agree with you. I get a lot of patients that had a reimplant somewhere and they're going to renal failure after the reimplant. So the reimplant makes them worse off than if, and I think maybe we're 30 or 40 people on the call here today. And I hope we've left each and every one of you with this message. Think 10 times before you decide to reimplant a boy with posterior urethral valves. Think, why am I doing the reimplant? And don't automatically do a reimplant because there's high grade 5 reflux in this population. Remember that the reflux is secondary, which means I need to fix the primary cause. And I need to analyze what's happening with storage, what's happening with emptying, before I even start thinking about reimplant. Because if they have high pressure storage and you do a reimplant, well, you guess what's going to happen to the result of their reimplant. If they're not emptying and you do a reimplant, the outcome of your reimplant is going to be pathetic. So I don't reimplant them, and if they're reimplanted and you're having a child with a poor bladder, then yes, I understand why you're doing an augment, but I want us to step backwards and be aggressive. Now, in your patient population, you are seeing a very different population than the ones I'm seeing. You're not seeing prenatally diagnosed valves. You're seeing children that are 3 and 4 and 5 years old that have had multiple episodes of sepsis. That's a different population. And in there, the management has to be tailored to that patient.
This has been a change, Dr. Khoury, during the past years. We see a lot now with antenatal diagnosis rather than neglected cases. It has been a change in the past few years.
No, I understand, but I bet you still see more patients that have been beyond that than I am seeing here.
Yeah, Dr. Hisham Badawi.
I need to ask a question, Ahmed, please. So, good evening, Professor Khoury. I enjoyed your lecture as usual. I learned a lot. As usual, your lecture opened more questions in my head. So, you changed your practice. I have never seen you doing a high loop ureterostomy or a loop ureterostomy in the past. This was.
It's not high, Ashraf. It's low. It's a low loop.
I understand. It's the idea of doing ureterostomy. I came from a practice where we used, before going to Toronto, we were diverting everybody through a loop ureterostomy. Then we moved on to valve incision. And I would say in the last 20 years, I would say it's very rare for us, maybe 1 or 2 cases in the 20 years to do upper diversion, or maybe 3 or 4 times vesicostomy. And I think introduction of valve ablation, primary valve ablation with the sickle-shaped blade with the wolf made a huge difference. But it's interesting. And to answer Professor Hannu, we had Hardy Hendren visiting us before going to Toronto in 1997. And we implanted everybody with posterior urethral valves. And the results were poor. So we learned the lesson. So I don't recall, Ahmed can tell you that, I don't recall reimplanting the ureters in a patient with valves in the last 20 years. I will look at your attitude now for supravesical diversion for those who don't do well. Very, very interesting. I know that your answer is never for bladder neck incision, and this is my point to Ahmed. I learned the idea of anticholinergics versus no anticholinergic in a prospective fashion came to my mind when I was in Toronto. When this girl fellow of Ricardo Gonzalez presented their primary data, she was in Montreal at that time. So that's why we did this study. And I encourage Ahmed, we have a huge volume of valve patients. So we should look at this bladder neck incision thing in a prospective fashion. I think it makes a difference. I think it's anecdotal, but we have to prove that. If it doesn't do well, do anything or do harm, I can never tell, but we have to look at it with a huge volume of patients. Again, I enjoyed your lecture very much, and it's very insightful for me and for everybody. Thanks.
Thank you, Asher. No, don't misunderstand me, please. I don't do loop cutaneous uretrostomies for many patients. It's 90% of my patients have a primary valve ablation with the cold knife, and 10% have either a primary diversion from the get-go. And we see maybe 10 or 15 patients a year at the most with valves. So we're not a high volume valve population like yours. So I might see 1 year 6, 1 year 10. So every 3-4 years, I'll do one loop cutaneous uretrostomy early. But 90% of the patients end up with valve ablation, and maybe 5-10% end up with secondary diversion if they're not doing well. At some point, they're not progressing. And so I'm more aggressive diverting them early rather than watch them deteriorate. If they deteriorate on a couple of ultrasounds, that's when I've been doing more of those loops. And it saved the day a couple of times for me.
Can I ask?
Low management.
Dr. Khoury, do you hear me? This is Hisham Badawi.
Hi, Hisham. How are you?
Very, very nice presentation. I enjoyed it very, very much.
Thank you.
I would like to ask you about patients who go into transplantation.
Yes.
What percentage of them who would require augmentation? And do you try the transplantation first because some of them improve their bladder function after transplantation? Or do you have some selection criteria who would use an augmentation before transplantation and who would do the augmentation after the transplantation? Right.
So, we have to fall back on what caused the renal failure. Were they in renal failure because of dysplasia, or were they in renal failure secondary to poor bladder management?
No, to poor bladder mainly.
Right. So the ones that went into renal failure because of poor bladder management, I think you are putting the transplant kidney at risk. If the one bladder caused 2 kidneys to get damaged, it will cause damage to the transplant kidney. So I'm personally, we did a paper in the early 90s where we took our valve patients that underwent transplant, and there was a group of 12 valve patients that had undergone transplantation. 6 of them had augmentation and 6 were not augmented. And the graft survival was better in the group that was augmented versus the group that was not augmented. It's anecdotal, it's a small patient population, but it's always taught me that when you see a child that's transplanted into their native bladder, when that bladder has caused their kidneys to fail, these transplanted kidneys end up with progressive hydro and they need a lot more management. So if that family is not willing to do intermittent catheterization after the transplant, you have to be very, very cautious. I'm much more sort of, if their bladder was bad to start with, I'd feel much more comfortable doing their transplant into an augmented bladder.
Okay, thank you.
Thank you for it.
Thank you.
A question, I think you answered it in your talk. So do you do routinely second look urethrostomy to make sure that the valve is adequately ablated?
Only if they're, I don't usually know, but only if their mother tells me that they're constantly dribbling when they're changing them, or if they aren't, if there's progressive hydro, I'll do a VCUG first before a second look. I'll do a VCUG. If the VCUG shows me that there's dilatation in the urethra, then I might do the a cystoscopy to just look.
Okay. I think we have answered most of the questions. I know you have a busy schedule, Dr. Khoury, so I don't like take a lot of time. I'd like to thank you very much for your time and effort and for your accepting this invitation, and I hope we'll meet you soon, inshallah.
No, listen, I'm very happy to do this with you guys, and if you want to do a regular, chat like that every couple of months, every 2 to 3 months, talking about different topics, I'm more than happy. And if you want to do clinical rounds where people bring cases and we can sit and talk about cases, each presents a case for discussion. I'm also happy to do that as a group. I think there's a lot of learning that we can do together like that.
Thank you so much, Dr. Khoury, again for your generosity, and thank you everybody for.
My pleasure, and thank you all for your attention. Bye-bye.
Thank you.